Good evening, everyone, and a very warm welcome on behalf of Scientific Committee of Amyris Diabetic and Endocrine Society. As you all are aware, today we are having our second webinar of the EDES Exchange Meet the Professor. This important initiative is part of the ongoing activity under the visionary leadership of Dr. Fatih Al-Awadi to increase the awareness and boost the clinical practice optimization among the healthcare providers. And we're having this valuable platform to discuss the challenging cases, to boost the academic knowledge, optimize the clinical practice, while the critical thinking. And we are having this clinical cases second session today under the patronage of EDS and via the proud sponsorship of Rigorati Rare Disease. I'm Dr. Fauzia, consultant endocrinologist in Dubai Hospital Endocrine Division and clinical associate professor at MBRU University. Today, after this EDS webinar, this is going on live in the YouTube channel of EDS, where those of you who could not catch up, this live is streaming. Later on, you can catch this on-demand webinar on the EDES Institute website. This activity is CME accredited, and after a few weeks, you will all, after filling the evaluation form, able to receive in your web mail CME certificates. After the presentations of the speakers, you will be able to type your question in the Q&A box, and we will mention after the speaker name, ask the question to the respective speaker about your questions. And if it is not being answered, we will try to answer them in the chat box for the same time, so you will be having your answers. Those of you who are having attendees and were familiar with the Professor Shlomo Malmed, we are honored to have him today. He's a distinguished endocrinologist and internationally recognized expert in pituitary disorders and neuroendocrinology. He's Executive Vice President and Dean of the Medical Faculty at Cedars-Sinai Medical Center, USA. He's pioneer in developing novel therapies for endocrine tumors and pituitary diseases. He's authored of 300 plus peer-reviewed publications and is a contributor to leading textbooks such as William Textbook of Endocrinology. He has served as a president of the International Society of Endocrinology and founding member of the Pituitary Society. Today's webinar is consist of two lectures. Our first lecture will be by Dr. Faryal Ishfaq, who is a specialist endocrinology in diabetic section of Dubai Hospital. She is certified in endocrinology as well as have done her internal board medicine by Saudi Commission of Health Specialty. She is also a member of Royal College of Physicians. She will be presenting today early stage acromegaly, exploring the interface between biochemistry and clinical expression. So today, let's have this great learning experience, and we will welcome Dr. Faryal to start her case. She can share her screen now.
Good evening, everyone. Good evening, everyone. Let's start our case for
Faryal, unmute
today's
yourself.
Oh, yes, I'm unmute. Hello, good evening, everybody. Good evening, everyone.
Dr. Faryal, you may continue.
Can you hear
We
me?
can hear you.
Okay, sure. Thank you so much. So let's start with our today's presentation. The first case, which is where I'm going to describe is early stage acromegaly, exploring the interface between biochemistry and clinical expression. I will skim through the brief case presentation, including the presentation and examination and the baseline findings. The flow of the presentation will take you from the case history to a brief description of the acromegaly, and then we will proceed with the detailed literature review pertaining to that particular case. So our first case, we have a 45 years old single female who is a university graduate, works as a corporate banker. She's a non-smoker and non-alcoholic. This patient was initially seen in endocrine clinic in February 2018, where she was referred from primary health center for the evaluation of abnormal thyroid function tests, which were noted since 2015. So the main complaints from the patient, which led to the checking for the thyroid function test, was chronic fatigue and weight gain, along with cold intolerance. Her main concern was that it's really hard for her to maintain her healthy weight. She has a propensity to increase weight very quickly. Overt negative review of systems included she denied any history of palpitations, heat intolerance, sleep disruption, headaches, and visual effects. No complaints of galacturia or changes in her physical appearance in terms of change in the hand, feet, glove, and shoe size. Her family history was negative for any neuroendocrine tumor. Her clinical examination during her clinic visit showed in baseline in 2018 that her blood pressure was normal. She was slightly tachycardic with a pulse rate of 101. Her weight was 68 kg and her BMI was 24.8. This was in 2018. Her most recent BMI is 26.4 in 2026. Her clinical examination was grossly normal. There was no goiter on examination, no evidence of hirsutism, acanthosis nigricans, and her visual field effects were perfectly normal. There were no signs suggestive of acromegaly and Cushingoid features, and she had a normal mood and effect. The baseline thyroid function test, which patient was referred to endocrine team, was actually, you can see in 2015, she had a normal free T4 with a suppressed TSH 0.24, followed by a 2-year course, and then she has a slightly lower normal free T4 11.9 with a lower TSH of 0.234. And in 2018, her free T4 was still on the lower side, however, TSH normalized. Her other pituitary panel showed a normal cortisol AM and ACTH level. Her gonadal hormones were within normal limits, and she had a normal prolactin level on the baseline investigations. It led to us to workup for the other anterior pituitary hormones for the evaluation of abnormal or discordant thyroid function test, which revealed that she had a high insulin growth factor level, which was 466 in 2018, followed by 291 and then 240. All these readings were around 1.3 times upper limit normal for that particular parameter. Her baseline growth hormone level was 3.94 in 2021, which was within the reference range. To bring it to your attention that the assay we used for the growth hormone level assessment was a Roche Chemilucent assay, and the analytical detection range of this particular assay can detect up to 0.03 nanogram per ml. So based on the current review from this patient, based on the history of inability to control her weight, mild cold intolerance, and high IGF level with a normal baseline growth hormone level. So here comes the first poll question: what should be done next? Should we repeat our IGF level? Should we proceed with oral glucose tolerance test to do an MRI of pituitary gland, or just for an observation? The question is open for the audience to answer, please. So can we see the results for the poll, please? Interesting. So it's a mixed response from the audience. 50% of the patients are in favor of OGTT and 50% are planning to do for an MRI pituitary. Only 10% of the 10% are saying to continue with observation, and even a lesser number of people suggest to do a repeat IGF level. So what did we do next for this patient? Because we had persistently high IGF level around 1.3 times upper limit normal since 2018, without any overt cause for falsely high reading, we proceeded with our first oral glucose tolerance test, which showed that BMI of 25 and patient needs to have another growth hormone level, ideally should be less than 0.4 nanogram per ml. But the lowest reading which we could get from our patient was 0.72, and it was at 90-minute sample. So this led to us to proceed with an MRI cell with a contrast in 2023 that showed a 2 mm microadenoma. So what we had here for our patient between 2019 and 2025, patient has persistently high IGF levels, which was roaming around at least 1.3 times upper limit normal. And the maximum reading which we had was around 339. That was in July 2024. And it was showing a severe discordance between the phenotypical presentation of the patient and excessively high IGF level. Here is the trend of the IGF level and growth hormone level over the number of years. If we see from the left side from 2019 till 2025, patient has multiple readings of high IGF level. And in the last two readings in 2024 and 2025, even the growth hormone exceeded the upper limit normal level. We ended up having at least 4 oral glucose tolerance tests for our patient, at least 6 to 8 months, 6 to 12 months apart in these number of years. And I'll just skim through the results we had for these 4 OGTT. This is the second OGTT we had in September 2023, where BMI of the patient is still 25. So we were expecting it to be less than 0.4. We managed to achieve that at 120-minute sample. The follow-up growth hormone suppression test in September 2024, we couldn't reach another growth hormone of less than 0.4. The lowest reading obtained was 0.62. And the most recent one in October 2025, where patient has gained a little bit of weight and BMI reached up to 26. We were expecting to have another growth hormone value of less than 0.2. Following in these number of years, patient underwent imaging at least 3 times, starting from 2023 till 2024 and 2026. In all these, we had a focal area of differential contrast uptake ranging between 2 to 3 millimeter, and it stayed more or less the same during these number of years. It did not increase in size. Here is the MRI cell post-contrast images for this particular patient. On the left side, we can see in 2026, the red arrow shows that there's an area of differential uptake. The area stays the same in 2024. On the left aspect of the pituitary gland, we can clearly appreciate that there's an area of differential uptake. So this area did not change in the size or in its character over the number of years. If we look into the systemic and the metabolic profile for our patient, apart from the pituitary hormones and aside from the insulin-like growth factor parameters, patient had an evidence of pre-diabetes mellitus with an HbA1c of 5.7%, and it does represent a critical metabolic biomarker given the insulin antagonist effect on the chronic growth hormone axis. Patient had undergone breast imaging profile, which showed the patient has multiple benign breast fibroadenomas, and she was being followed by the surgical team. In ultrasound thyroid, we came to know that she had multiple benign small colloid cysts, but no suspicious features to be worried about. Her DEXA scan had not revealed any evidence of bone involvement in terms of osteopenia or osteoporosis. So let's come to our case summary. We have a young female who is single, has a metabolic background of pre-diabetes mellitus, tendency to weight gain, some small thyroid colloid cysts, and breast fibroadenoma. Persistently biochemical low TSH and low normal T4, which initiated the path towards the pituitary testing. Ended up having persistently high IGF level over last 8 years, and each time it's more than 1.3 times upper limit normal. Out of 4 oral glucose tolerance tests, 3 were non-suppressed. We couldn't reach to the appropriate cutoff for that particular BMI. And we have a static imaging finding of 2 millimeter pituitary microadenoma with no significant increase in size or change in the character. That leads us to our second question, all questions for the audience. What is the likely diagnosis in our case? What exactly we are dealing with? So let's all answer this question and move forward to the more interesting things. Can we kindly see the answers for the poll questions if they are ready? Excellent. We have a huge number of audience who have chosen subclinical acromegaly as the probable diagnosis. We have a good number of participants who still think it's an acromegaly and some supporting the other options as well. So let's talk about what do we have and what are the possible diagnoses in this particular case. We will start our literature review and some brief explanation about the acromegaly. So it's a rare disease. Its prevalence is only 5.9 per 100,000 patients. And the worrisome thing is that there is a significant diagnostic delay, which is documented to be at least 10 to 14 years, and there are multiple causes for that. One of the major causes is the disease evolution is very subtle and very slow, which leads us to a delayed diagnostic. And then we have a long latency period in the disease between the starting of symptoms and the actual origination of the disease, and there's long latency challenges there. We have fragmented care across the separate medical specialties. It's not a single organ involvement, it's a multi-system involvement. And most of the time, the diagnosis is based on the constellation of different systemic involvement that lead us to diagnosis of acromegaly. And the most important thing, relying on the overt phenotypical changes very pertinent to acromegaly are slow to appear, but relying on the overt changes can lead to the delay in diagnosis for an average of 10 to 14 years. So there is a variable shift in the phenotypic clustering. Not each patient is same, and not all of them present with the same clinical parameters. And the evolution of the symptoms might span over a large number of years. Patient can have one symptom at one time and the second, and ultimately the development of the overt acromegalic phenotypic features. So it's a multi-system symptom clusters. So instead of waiting for us to let the patient develop physical features, we should identify the combination of multiple comorbidities appearing together. Initiation or on revelation of multiple system involvement at the same time or in different time zones, we should always have a low suspicion of involving something which can lead us to diagnosis of acromegaly. We all know that the acromegaly diagnosis has never been a very straightforward, and it has its own a long history to talk about how it has evolution. The most recent consensus guideline for 14th acromegaly consensus conference statements regarding the diagnosis and therapeutic defines acromegaly as having a high insulin-like growth factor, more than 1.3 times upper limit for age only, and the characteristic signs of the disease. So it tells us that the history of the IGF evaluation will include in the 7th consensus statement. First, there have been contribution from the age-related IGF changes. So with the passage of time, we have come to this refined conclusion of the acromegaly diagnosis, but still the disease is not that much straightforward. So in the equivocal results where we are not sure about IGF-1 is giving us the straight answers, we can have a repeated measurement of IGF, which was being done in our case, and still we couldn't reach the diagnosis. So ultimately, oral glucose tolerance test can have a useful value in the diagnosis of acromegaly. So if the oral glucose tolerance test is performed, we have to give patients 75 grams of the glucose after a fasting of at least 8 to 10 hours, and we have to assess the growth hormone and other value at different intervals time. It's 30 minutes, 60 minutes, 90, and 120 minutes. And to bring it to your attention, the most important thing in this 14 consensus acromegaly conference guidelines that the BMI cutoff, BMI-based and other cutoffs are different. So if somebody is having BMI of less than 25, then other cutoff we expect to get in OGTT should be less than 0.4. And if the BMI crosses more than 25, it shouldn't have, we should reach another value of less than 0.2. So it's a spectrum of the disease. It's not a straightforward disease. Mostly all the endocrine diseases share a spectrum of the pictures and spectrum of the clinical phenotypes. The same happens in this particular entity in acromegaly, that the symptoms can, or the spectrum of the disease can expand from silent somatotrophinoma to a subclinical acromegaly, can reach up to micromegaly, and then ultimately coming up with the overt phenotypical features of acromegaly. I'll explain this in detail in this particular slide, where on the top left side, we have silent somatotropinomas. So in this particular population or subgroup of patients, we do not have any signs and symptoms. We have normal IGF levels, we have normal growth hormones level, but patients are diagnosed on the basis of positive staining for somatotrophs on histopathology. On the top right side, we have the next category, which is the continuum of the spectrum in the subclinical acromegaly, where patient can have very non-specific signs and symptoms, can have high IGF level, but inability to suppress the growth hormone level and a positive imaging. To be very clear about the subclinical acromegaly, when we say imaging positive, it does not mean an invasive disease. It's a very subtle findings on the imaging can help the patient classify in this particular category, which is subclinical acromegaly. Then comes a micromegaly, where we can have subtle signs and symptoms of acromegaly, which can preclude to do the investigations to look for high IGF level and growth hormone levels. And there are some categories of micromegaly where we are having high IGF level with a suppressible growth hormone level. The last half of the spectrum is the acromegaly, where we have overt phenotypical features of acromegaly. We do have a high IGF level and inability to suppress the growth hormone level, and with the positive imaging findings suggestive of invasive or non-invasive disease. So if we try to put our patient in any of these categories, so what our understanding is that patient most likely fits into subclinical acromegaly, where we have non-specific signs and symptoms. We do have an high IGF level and inability to suppress growth hormone levels at least 3 occasions out of 4, and we have a positive imaging finding. This spectrum of the disease leaves us with the diagnostic synthesis and the dilemma at the same time. So we have a diagnostic paradox here. We have clinical normalcy. We have phenotypically completely normal female, no signs of overt growth hormone involvement in terms of no facial coarsening, no skeleton involvement or soft tissue swelling. But at the same time, should we say that it's a preclinical acromegaly or subclinical acromegaly, where a somatotroph adenoma has been caught very early in the diagnostic stage before the manifestation of the clinical phenotype? The other possibility, there is a lot of discordance between IGF levels and OGTT, but we do have an anatomical lesion. So we do not have only biochemical abnormality, we do have an anatomical lesion which is not being explained. Or is it just an indolent pituitary endocrine tumor which is lying up there in pituitary without significant manifestations of non-suppressible growth hormone? Or it is still the low proliferative capacity and the growth hormone level is low enough, or it's less enough to cause the symptoms. Or we might have a third category, that it's a physiological growth hormone variation or an elevated set point, because that can also have some partially retained hypothalamic feedback inhibition loops and cannot show up on the oral glucose tolerance testing. Here I completely finish here the case discussion and the brief discussion around acromegaly or different subclassification of acromegaly, a different spectrum of the disease. I would like to skim through the literature review where it can be, the slides could be busy at point, but I would like to clear it that I'm going to discuss 3 major studies focusing on the micromegaly and 2 major studies where we are going to highlight the importance of follow-up cases of subclinical acromegaly. So let's start with our first study. So the first study done in 2022, where they looked into the characteristics and treatment outcomes of micromegaly, acromegaly. Here still they did not document either it's a micromegaly or acromegaly with apparently normal basal growth hormone. So it's a retrospective study. And the aim of the study was to find out how do the patients do if they have a normal basal growth hormone at diagnosis. They do have a high IGF level, but their basal growth hormone at diagnosis, how it's going to impact the outcome of the patients and what are the basic characteristics of this particular population. So what they did, that patients who had some classical acromegalic symptoms in terms of phenotype and had an IGF level 1 time upper limit normal and a glucose suppressed growth hormone level of 0.4, and the basal growth hormone there was considered normal if it was less than 2. So to keep in mind, all these studies and the literature review is before the 14 consensus guidelines or 14 consensus acromegalic papers. So the cutoffs have been different, what we know now from 2024 onward. So what they figured out, they had total of 74 patients, and out of these 74 patients, they all had high elevated basal growth hormone level, if you see in the first highlighted area, and only 6 patients had normal basal growth hormone. So all these patients had high IGF level. Out of these who had high IGF level, only 6 had normal basal growth hormone. This is something striking. A patient with acromegalic features, clinically, a high IGF level, one time upper limit normal. How do the patients with low basal growth hormone behave differently? If we look into the second highlighted area in another post-glucose growth hormone level, the lowest level which was achieved was 0.74. And the IGF level was around 50% less in this particular patients with the normal basal growth hormone. They concluded that patients who have normal basal growth hormone level, they are older at their presentation. In addition to that, they had microadenomas in both of these patients in this particular group, and the post-nadir glucose, IGF and growth hormone levels were very low than the patients with elevated levels. So what they did with these 6 patients, these 6 patients have moderate to severe symptoms of acromegaly. They have high IGF level and a normal basal growth hormone level, which does not coincide with the IGF and the acromegalic symptoms. So they did treat these patients somehow. 3 patients underwent transsphenoidal surgery. 1 was treated by octreotide, 1 was treated with cabergoline, and 1 patient presented with apoplexy and did not require any treatment. So what happened to all these patients? Out of these 6 patients, 4 underwent into remission after surgically. It means they had complete normalization of their IGF levels and the growth hormone they were able to suppress after OGTT. And out of these 4 patients, 1 patient had persistent disease after the surgery and had to receive the octreotide. So this was in the first study where they concluded that then having a normal basal growth hormone does not mean that we do not treat the patient. 75% of the patient can still go into the remission after the treatment and they can have the resolution of their symptoms. Let's move into the second study for focusing on the micromegaly, or the patients who are having persistently high IGF level and growth hormone suppression level. So here they had around 53 patients. So in this particular study, they divided the patient in 2 groups. Out of these 53 patients, 25 patients were those who had done an IGF level for the evaluation of clinical suspicion of acromegaly. And 28 of these patients, they had undergone IGF levels for some other reasons. Like out of them, 11 had done suspected workup for hypopituitarism, 7 for adenomas, 3 for emptyselia, 1 for Cushing, and 1 for hypoprolactinemias. So all these patients ultimately had high IGF level, but the initiation point of the workup for IGF was different. 25 patients who clinically had suspicion of acromegaly, if we look into this group, they had more clinical symptoms or associated comorbidities in comparison to the second group, where they incidentally found that the high IGF level was there. So if we look into the left half of this particular table, all the patients, 100% of the patients had acral enlargement in the group 1 who had clinical suspicious of acromegaly. Around 10%, 10 of them had paresthesias, 7 had headaches, 3 had hyperhidrosis. So if we compare them to the patients who do not have clinical symptoms suggestive of acromegaly, they were having low number of comorbidities. The same has been explained in this one, that when they looked into the age parameters, the patients who in group 1 of mean age were around 59 years, and they have more comorbidities rather than the patients who were just incidentally found to have high IGF levels. The goiter was present in more number of patients, carpal tunnel risk was more, colonic polyps were found in around 6 patients, and the risk of malignancies were higher with the patients who had clinical symptoms of acromegaly, high IGF level, and unable to suppress the growth hormone levels. Out of all these patients, in 25 patients in the first group and 28 patients in the second group, only 2 patients had macroadenoma in the second patient, whereas it was an incidentally found. These patients were being evaluated for some other reasons. And only 2 patients had emptyselia in the first group and 6 in the second group. So what they concluded in this particular study in 2021, that patients with micromegaly, even in the presence of suppressed growth hormone, they have a high rate of comorbidities. We all know that if patient has a clinical feature suggestive of acromegaly, high IGF level and high basal growth hormone level, inability to suppress growth hormone level, they have high risk of comorbidity. But this particular paper, they focused that even in the presence of suppressed growth hormone level or low basal growth hormone levels, the risk of comorbidity is high. So this particular subset of the patients is something we cannot ignore. We still have to take these things into account. And they propose that we need a revision of the growth hormone NADH cutoff that can be considered for the further testing and the further follow-up of the patient. So as this was in 2021, we do have some refined criteria for the lowest growth hormone level in OGTT, which further can help us if we look into the retrospective that many patients will out of this subgroup. Then the next paper where they discussed, it's a very old paper around 10 years ago in 2016, but very interesting one, that why we have in some patients elevated IGF levels and the growth hormone suppression, why there is a big discordance between the IGF level and growth hormone. So they had around 46 patients in this particular cohort who had suggested clinical scenario, suggestive of acromegaly, who had done IGF level outside the pituitary and pregnancy window because the targets are different, and they had followed them for a period of 5 years. What happened here, they had 46 patients on the left side, starting with the left side, and they had high IGF level, but all of them had a suppressible growth hormone level. So initial IGF level was in the range of 1 to 1.5 upper limit normal. When they followed these patients, 42 patients at the end of 5 years, 15 out of 42 had already normalize their IGF levels without any intervention. And it was confirmed at 2 measurements. The rest of the 27 patients who had persistent IGF levels again underwent OGTT, and they all confirmed the growth hormone suppression in all. So MRI was done in those patients who had persistent IGF levels. Only 2 patients had microadenomas. So the results were saying that even in the patients with suggestive clinical scenario and persistent elevated IGF levels, acromegaly is very unlikely. So surprisingly, the data over the number of years is very conflicting. At some point, they say, like in 2016, that having a persistently high IGF level with the normal growth hormone is just like a high IGF level. Maybe it's a false positive result, or there are some underlying factors which are interfering with the assay. However, all these studies have been done when they tried to remove all the confounding factors to keep it very fair. So conclusion by the researchers here, in particular in 2016, they said we don't know that whether these individuals correspond to a subgroup of the population that have this concentration of IGS outside the normal range, or they are more sensitive to endogenous growth hormone, or they have a growth hormone's hypersecretion, although it's not in the tumoral range, and it is responsive as well to the OGTT. So we couldn't reach any particular conclusion by this, that having an IGF alone, is it safe to follow for a couple of years with the growth hormone suppression? We still couldn't get an answer to that until the late studies are out. So this is the review regarding the micromegaly. Now I'll be moving about the subclinical acromegaly, which is at the same level of interest as micromegaly, but as our case mainly follows in this particular category, it's very interesting to explore more in this area. So there's a beautiful paper on subclinical acromegaly in 2022. The question is very striking: to treat or not to treat. So this was the first paper on subclinical acromegaly, where they looked into 6 patients who had mild biochemical acromegaly, but without specific signs and symptoms. And it showed that the extremely low, the disease load was very low. The total SAGIT score, we had 22 max if we keep into consideration of all the scoring parameters. And the mean value of total SAGIT score maximum in this was 4.8. So they had defined subclinical acromegaly as somebody who is having IGF level 1.3 to 2 times upper limit normal. They have at least one sign or symptom of acromegaly, which is again non-specific signs and symptoms they're highlighting here, which could be headache, swelling, or joint pains, or up to 2 associated comorbidities: diabetes status, hypertension, sleep apnea, or heart disease, or evaluation of other hypopituitarism. And they should have an evidence of pituitary adenoma on imaging. So it's very important to go through all these 6 patients which they looked into the subclinical acromegaly. They all were being evaluated for some other reasons. So the first patient was a 35-year-old male being evaluated for erectile dysfunction and found to have high IGF level of around 2 times upper limit normal and a concomitant microadenoma 4 mm. Second patient was being evaluated for chronic headache, and again, this patient in particular, that was the only patient out of 6 who had a macroadenoma of 12 millimeter. The third patient was a female, 43 years old, was being evaluated for mild enlargement of the feet and was found to have IGF level of 1.3 upper limit normal with a 4 millimeter microadenoma. I'll come back to this slide. Looking into the patient number 4, 5, and 6, they all had some either non-specific symptoms, like patient number 5 with snoring with pre-diabetes and hypertension, and the other two were evaluated for some other reasons. Out of these patients, 3 patients had undergone transsphenoidal surgery, and this is very important and very interesting to see the histopathology reports or the results of these patients. If we see patient number 1, 2, and patient number 6, they all did the surgery and found to have a Ki-67 index of maximum of 3%. So none of them was reported to be very aggressive. Out of these 3, 2 went into complete remission, and the first one had to be treated with lanreotide and octreotide. All of these patients underwent somehow on any of the treatment, either surgery or with the somatostatin receptor agonist. So they did not leave any of the patient, even who were found to have an IGF level initial and a concomitant imaging evidence was there of some adenoma. And if we see, out of all these 6 patients, 5 went into hormonal remission with a significant shrinkage in the tumor size, even to the response to a somatostatin receptor and agonist. So what happened after this, after looking into, so what was it was very interesting for me to know that why they looked into the patients who are being evaluated for some other reason and then they got treated. The initiation of this paper was basically on the patient number 3 who had mild enlargement in the feet, and she was going evaluation for TIA. And this particular patient reported to have normalization of her facial look after the treatment. So one incidental finding led to this beautiful paper, which coined the term of subclinical acromegaly. So how did they define this particular term in 2022? It was the first entity at that time that patient can have minimal clinical features without significant biochemical abnormality and absence of an invasive tumor on imaging can have the diagnosis of subclinical acromegaly. The biochemical and imaging abnormalities were really mild in these patients. All the IGF was less than 2 times upper limit normal, and the random growth hormone levels were less than 1, and there was an intracellular microadenoma was there, apart from the exception for one case who had 1.2 centimeter. So subclinical acromegaly was defined as a new entity, which is a continuum of the spectrum and can be a bridge between silent somatotropinomas and active acromegaly. So in conclusion, it's a true entity as per the researchers. Maybe it's representing early, or the disease has really a sluggish course. And we always have to look into the risk-benefit ratio for the intervention. And it's a very narrow window to think, should we treat it or not? So individual strategies are very strongly recommended in this particular subgroup, but the treatment offers and the clinical benefits out of it are really, really variable. We do not know that either all the patients will respond in the same way or not. Let's go to the second half and the interesting half of the presentation, where in 2025, a very long-term follow-up of 2 cases of subclinical acromegaly was published. And by now we know what do we mean by subclinical acromegaly. Patient can have very non-specific symptoms, high IGF level. There is an imaging evidence of a lesion in the pituitary gland, which is not invasive. So the first case in this particular paper in 2025, it's a young female who is 34 years of age and complaining of lethargy, some impaired cognition and headaches, and was found to have an incidental MRI cystic pituitary lesion. Because she did reveal a pituitary lesion, her hormonal workup was done, which showed a high insulin growth factor level, which was documented to be around 823, and the rough reference range upper normal limit is 227. So she underwent an oral glucose tolerance test and reported another growth hormone level of 7.5. So to be noted that if she doesn't have any clinical features very typical of acromegaly, but it's a very high another growth hormone level in the OGTT, which is far, far away from the targets, irrespective of the BMI. So there is no point of ambiguity here. So this patient underwent the transsphenoidal surgery, and after the surgery, her IGF level improved but did not normalize, but there was no change in her symptoms of headache and arthralgia. Because her symptoms persisted, so she was started on lanreotide 90 milligram every 3 weeks, which results in the improvement in symptoms and normalization of IGF level after a period of 3 months. So in this particular subgroup, if she did not improve with TSS and IGF did not normalize, it means her symptoms did not improve. So when this patient was followed after 6 years, she had improvement in arthralgias and her cognitive symptoms, and she continued to receive lenalidomide every 3 weeks. That takes us to our first case, the one she did a transphenol surgery. We had a histopathology report which was showing that it is a somatotroph tumor with a large cell with eosinophilic abundant cytoplasm, and it was positive for growth hormone staining. There was a low mitotic activity, and the Ki67 index was reported to be 1.4%, and there is absence of p53 protein expression. Let's move to our second case. So on the contrary, in the second case is an elderly female. She's a 78 years old female. She has main complaints suggestive of mania and depression, and was noted to have some generalized joint pains for several years before bringing it to the presentation. She did not have any previous suggestive history of endocrine tumors or acromegaly. She was being worked up for primary hypoparathyroidism because of high calcium level of 12.7 and a very high PTH level of 138. During her workup, to look for other pathologies, we found to have a pituitary adenoma of 1.5 centimeter and an IGF level of 768 nanogram, which is way more than 1.3 times upper limit normal. Her OGTT also showed failure to reach the another cutoff value of growth hormone, and it was documented to be 8.9 with a concomitant blood glucose of 174 at 60 minutes of OGTT. This patient did undergo for parathyroidectomy, but she didn't agree to go for pituitary surgery. So unfortunately, we don't have the data about histopathology report of this particular patient. But she was treated with long-acting octreotide 30 milligram monthly for the symptomatic control, and she did improve. She noted improvement in her arthralgias after the medication, and follow-up IGF levels started to normalize. Her follow-up IGF level was within normal limits for her age, which was 161, but MRI did not show any significant change in the adenoma size. It remained stable. So we discussed two main cases of subclinical acromegaly where patient was seeking attention for non-specific symptoms of arthralgia, headache, some cognitive symptoms without any overt signs and symptoms of acromegaly. Both of them had significantly increased IGF levels and unable to suppress the growth hormones. But clinically, the clinical picture was not matching, but both of them found a benefit out of the treatment, irrespective of the modality of the treatment. Either it was surgery or the medical treatment. But the reassuring thing in the first case is that the histopathology report was not associated with any aggressive behavior or invasive behavior of the disease. The same goes with the first literature review of the acromegaly of 6 patients. Whoever patient underwent transphenol surgery, we got the maximum Ki67 index of 3%, which is very reassuring. So the conclusion from these two patients, both had non-specific symptoms, both clinically had no features of acromegaly, no associated documented comorbidities which could contribute us or which could give us the constellation of the symptoms to say, yes, it should be thought from the beginning. Both were screened for colonoscopy and echocardiography, which was normal. They had different treatment course, but both of them showed the improvement. None of them developed the acromegaly features on a very long follow-up. First patient was followed for an average of 6 years and the second for 9 years. So we are still at a point where we don't know either patients are treated right at the right time before the overt symptoms development, overt phenotype development, or we have some questions now for the professor to guide us in this particular scenario that we have for our patient. So here are the questions. We have total 4 questions to the honorable professor.
Thank you. That was a terrific presentation, really super. Congratulations, Dr. Ashfaq, really nice. I am trying to share my screen. Can you allow me to share? Thank you. So after that very extensive and comprehensive review, there is not much for me to add. So let me use this opportunity to take you through a diagnostic schema, which is hopefully current to today, and see how it fits into the patient that we saw. So this is a patient with a high IGF-1 that you presented. And if you look carefully at the IGF-1 levels, as you correctly said, they've been persistently high for almost 8 years. But what is striking about the IGF-1 pattern which you presented is the fact that the first IGF-1 level in 2018 was actually 466, which is extremely high. And thereafter, they were hovering around 250, 250, 220, 230. But what is intriguing is the fact that there was this spike of T4. And one wonders whether, in fact, even though there were no real antibodies detected, that the patient had some subacute thyroiditis with a spike of T4, whether or not that is connected to the high IGF-1 at the time, I don't really know, but I don't think so. So in effect, your patient with a high IGF-1 is a victim of medical progress, because 10 years ago, you would not have had this case presentation, or because there would have been no good IGF-1 assay, you wouldn't have sent the patient for an MRI, and the patient's asymptomatic. So basically, this is an incidental IGF-1-oma. You've incidentally picked up a high IGF-1 because you were pursuing a high T4 levels. So let me immediately jump to one conclusion which you asked about, and that is the silent acromegaly or silent somatotroph adenoma? And the answer is no. By definition, it's not silent because there is a high IGF-1. And so one of the possibilities, because the initial high IGF-1 was so high and the subsequent ones were lower, one possibility is that the patient had true acromegaly at the time, but maybe had some self-infarction of the adenoma with some shrinkage of the adenoma and a less active disease. So let's go through the tree for what one should do for diagnosing a patient when you do find a high IGF-1 level. So if the IGF-1 is normal, then you have no problem, and you wouldn't have had a problem with this patient because a normal IGF-1 makes acromegaly extremely unlikely. You should consider pseudoacromegaly, a previous infarction as we spoke about, or previously treated acromegaly. But in effect, a normal IGF-1 will exclude acromegaly and would not have set you on this path of discovery for the last 8 years. If the IGF-1 is mildly elevated, you are absolutely correct to perform an oral glucose load, and then in your patient, you would have hoped to find a non-suppressed growth hormone in order to make a definitive diagnosis. However, if IGF-1 is suppressed, and herein lies your problem, your question, is acromegaly unlikely or not? And the issue that we face is, and you've highlighted it beautifully, up to 30% of patients can have acromegaly and still have normal OGTTs. And therein lies the problem which your patient poses for you. If the IGF-1 is very high and you have a clinical suspicion, it's easy. You can make a clinical diagnosis of acromegaly, move on to a pituitary MRI, and if the adenoma is suitable for surgery, you offer the patient surgery. If the adenoma of the patient is not suitable for surgery or refuses surgery, then you can move on to medical treatment. And in very, very rare circumstances, and your patient does not have this, these patients may have an enlarged pituitary from ectopic acromegaly, and in that case, you would have measured a GHRH and do a chest CT and perhaps even do an Octria scan. These are extremely rare patients. I don't think that your patient fits into that category because you do have a positive pituitary MRI. And you mentioned one very important topic, and that is the delay in diagnosis. And even today, this is a paper from 6 years ago, but even today, if you look at the recent literature, diagnostic delay is extremely problematic. And the delay is a mean of 5.5 years. And this is a study from Sweden in which they followed 603 patients. And you can see that the patients with delayed more than 10 years have much higher comorbidities, up to 6 comorbidities per patient. And this is due to the fact that there's long exposure to high IGF-1s. So this slide, although it's a lesson for all of us about making an earlier diagnosis, because if there's no delay, comorbidities are very low, this slide is a lesson for your patient in that you don't want to expose her to many years of high IGF-1. because it's the time of exposure, it's the massive IGF-1 exposure over years and almost decades, which is so deleterious to comorbidities. And I would strongly suspect that if you left your patient untreated, despite the good literature review that you gave us, if you left, and I don't necessarily agree with the conclusions of all those papers, which you quoted for us so beautifully, and that is, I don't believe that it's safe for a patient to have a long exposure to high IGF-1 levels, because high IGF-1 levels are deleterious for comorbidities, and ultimately they are deleterious for mortality. So what are the determinants of IGF-1 concentrations? And you alluded to most of these, and let's just review them. So when you have a patient with decreased IGF-1, then anorexia and malnutrition should be excluded. And you said that your patient went onto a diet and tried to lose weight, but in fact there was no evidence that she was cachectic. So that would not explain her IGF-1 response. She clearly does not have severe liver or kidney disease, and she doesn't have uncontrolled diabetes. And these three conditions will necessarily decrease IGF-1 levels. What is very important is oral estrogen. And an oral estrogen will in fact give you a falsely low IGF-1 because estrogen causes growth hormone resistance. That's why women have lower IGF-1 levels than men. And therefore, even in the face of acromegaly, the IGF-1 levels may be lower because the peripheral action of growth hormone is attenuated by estrogen. And severe obesity, if you skip to the bottom one, also would, and your patient does not have obesity. But the most important lesson that I'd like to bring out today is there are only two conditions which are associated with high IGF-1 and not acromegaly. And that's pregnancy and late puberty. So if you find a high IGF-1 level in a patient who's not pregnant and is not in the late spurt of growth at the age of 16 or 17 or 18, and the IGF-1 is high, that is acromegaly. There are no other false positives that we know of. And so I think that that is extremely important. The one caveat to the slide is the IGF-1 assay itself. And you've obviously got an excellent IGF-1 assay. You rely on your IGF-1 assay. And most importantly, the IGF-1 assay should be age-specific and sex-specific in terms of offering you reference ranges. Again, your reference ranges will be lower in women, certainly lower with age, and you've got to make sure that your patient is or isn't on estrogen and is or isn't postmenopausal in order to make that interpretation. But if we move to your results of the OGTT, you were correct. The cutoff today are 0.4 to 1, and it depends on the growth hormone assay, and you've got an excellent growth hormone assay. But there are limitations. As I mentioned, about 30% of patients with mild acromegaly are going to give you a limited interpretation of the test. Often these patients who do suppress have microadenomas with baseline growth hormones of less than 4. They're usually healthy lead individuals. But if they're taking oral estrogen, then the results should be interpreted in that light. And if the diagnosis is unclear, as it was in your patient, you continue to repeat the testing, and that was exactly the appropriate position that I would have taken in terms of a pathway of diagnosis. So if now you're faced with a dilemma, what do you do for your patient? So for the patients that I've illustrated in these beautiful images, it's easy because you have a phenotype, you have a clinical disorder, and you can follow it. So your goals would be to eliminate morbidity, to reduce mortality, to enhance quality of life, giving a safe treatment, control these mass effects, either by surgery or by medication, control growth hormone hypersecretion, maintain pituitary function, and follow them by age-adjusted IGF-1 levels, and hopefully your comorbidities will improve. Your patient, unfortunately, will not give you this clean-cut opportunity to follow because there are no comorbidities. So all you can follow are the age-adjusted IGF-1 levels. And the curious situation of your patient is, and I was very questioning about this to myself. I'm surprised because the younger patients, and she is a young lady, usually have more aggressive adenomas, and they don't have these small, what you call subclinical acromegaly. They have florid acromegaly. It's the older patients who are 60 and 70, 80, even 90 years old. We have some patients who have these small tumors with mildly elevated IGF-1 levels. So she does not fit the classic pattern. Women usually respond more favorably to medications, and any adenoma size and invasiveness will adversely impact surgery. So your patient has a small adenoma. If you do undertake surgery, the surgery will be relatively easy with a good result, but I would not recommend surgery for your patient. And we do have, if you look on the right here, we do have many opportunities for treating these patients that are not surgical. We could offer these patients a somatostatin receptor ligand, either an injectable or an oral. We could offer them a dopamine agonist, which would hardly ever works in our hands. We don't use cabergoline, it never works. Or we could offer you a peripheral receptor-directed drug, a growth hormone receptor antagonist, pegvisomant, and now there is a second growth hormone receptor antagonist in development called MAR002, and the results were just published in the Endocrine Society meetings last week, showing a very similar action to pegvisomant, but more marked suppression of IGF-1 levels. And so we have a whole host of opportunities to treat the patient, and I would definitely treat your patient medically. I would not subject her to surgery. And the question would be, well, what medical treatment do you use? And the medical treatment that I would use for this patient is paltusotine. And paltusotine is a somatostatin receptor agonist. It's an oral drug. It has just been approved in the USA, and I believe it is approved in the rest of the world as well. And this is these are the results of the phase 3 trials of paltusotine, an oral treatment of acromegaly. And you can see, as compared to placebo, these are the proportion of patients who normalize their IGF-1 levels, over 80% in both in the first study, and in the second studies were patients who were previously medically untreated. Almost 60% of them, as compared to 5% of placebo, are going to be controlled. Why do I suggest paltusotine for this patient? Because it's oral and it's daily, so you can always titrate. Giving this patient a long-acting injectable for every 30 days won't give you much opportunity to titrate. And I would urge you to give this patient paltusotine, a daily pill, relatively safe, similar side effects to the injectables, except obviously no side effects from the injection site itself. And because it's daily, you can titrate. You will be able to titrate the dose, titrate the opportunity by measuring IGF-1 every 2 weeks, or every 4 weeks, or every 6 weeks, and then simply titrate the level of your medication, the dose of your medication, by the IGF-1 response. And I strongly suspect that your IGF-1 levels will normalize. At the end of 4 months, I would suggest that on paltusotine, you repeat the MRI, and you would hope to see the microadenoma disappear or shrink. That will be both a therapeutic response as well as give you a diagnostic response that your patient does in fact have what you called mild or subclinical acromegaly. But I definitely think that the patient should be controlled medically, because the adverse effects of long-term exposure to IGF-1 are too serious to allow a young lady to be exposed for the subsequent decades. And just let me end off by giving you the consensus guidelines conceptual shift, which occurred over the last year of consensus since 2018, when your patient was first diagnosed. So when your patient was first diagnosed, acromegaly was regarded as a primarily biochemical model where we had to suppress growth hormone and normalize IGF-1. But since then, we have a far more comprehensive, holistic approach to acromegaly, where we are aiming to manage comorbidities which your patient does not yet have, but I suspect will develop over the next decades if she continues with high IGF-1 levels. Patient-specific metabolic risk, and you have appropriately followed her with looking for diabetes and for glucose resistance. The cellular phenotype of the adenoma, you don't know because you're not subjecting her to surgery, but you can certainly follow this with the MRI. Clinical symptom burden for your patient luckily is 0 right now, but I strongly suspect that she will develop glucose intolerance and mild arthralgias if she continues with a high IGF-1 level. The adenoma control can be followed with an MRI, and the biochemical control will be your marker, which you will follow, and hopefully you will be able to we will be able to email each other, and you can tell me that her IGF-1 level was normalized, taken an appropriate dose of paltusotine. So let me end off there and give you time for opportunity for questions, and I look forward to seeing the next patient. Thank you.
Thank you so much, Professor. Thank you so much for the detailed feedback and the suggestion for our particular patient. Thank you.
Excellent patient. Congratulations on your workup.
Thank you, Professor Malmet. And I just want to ask you one question over here regarding this particular case. In case we do not select the medication you advise and we go for conventional treatment like octreotide, do you think that if patient tolerates that and accept that would be an alternative good option for her?
And what are you? Sorry, you cut out.
Right.
What would be an
Right.
option?
If we give her, instead of somatostatin receptor ligand inhibitor, directly we give her octreotide, LAR. So would it be a alternative good option for her treatment?
It would be a good option, but it's going to be very difficult to titrate the dose. Be
Okay.
very difficult because you're going to want to know quickly whether she is or isn't responding. Because if she's not responding, then you'll stop the treatment. And if you give an injectable, it's going to take you 3 months to achieve plateau. And then if you want to lower the dose, it'll be another 3 months. So I think that the tweaking of the dosage is much easier with a pill every day. That's the reason that I recommended the pill.
Thank you so much. Really appreciate your in this particular case. And here I would like to introduce our second speaker, Dr. Morgan Menar, who is a specialist endocrinologist in Dubai Hospital, clinical assistant professor at MBRU, and he's a recipient of a prestige award, Dr. MMS Ahuja Book Prize Award in Endocrinology during his fellowship there. So the case 2 is involved when cure eludes, a case of persistent Cushing syndrome. So please let's welcome Dr. Morgan to start his challenging and as well as quite interesting case together for active participation with you.
Thank you, Dr. Fauziya. Is my slide visible?
Yes, it is visible.
Yes. A very good evening to all. We all know Cushing syndrome is a very difficult to diagnose in the OPD or clinic setting, especially when we are trying to differentiate between a true Cushing's from a pseudo Cushing's. But even when you diagnose Cushing syndrome correctly, if the etiology is Cushing's disease, sometimes after surgery, the cure becomes difficult. Today, I am going to discuss one such patient and share the journey of this patient who underwent multiple interventions which seemed to be appropriate at that point, but all the intervention failed and she's still having persistent hypercortisolism. Before I go into the case per se, I will just briefly rewind our basics on Cushing's disease. Cushing's disease is, though it's a rare disease per se, it's a common cause of endogenous hypercortisolism resulting from ACTH secreting pituitary adenoma. The first line of treatment in such cases is transperineal surgery, yet remission is not universal. Though most cases go into remission, a subset of patients still tend to have persistent disease. Even in patients who go for remission, they can come back with recurrence. So a persistent disease or a recurrence is associated with ongoing morbidity and increased mortality. And management after the initial treatment failure requires an individualized, multidisciplinary decision making and possesses a clinical challenge. So with this background, let's go into the case. We have a 31-year-old female who is Haitian, married, with underlying comorbidity of type 2 diabetes and dyslipidemia, and she has very significant past history before presenting to us in January 2026, that is this year. So the next few slides, the information that I'm going to share is based on available records. Sometimes the diagnostic workup may not be complete up to the standard of care. The presentation started way back in 2019 when she had a clinical feature suggestive of Cushing syndrome in terms of weight gain, purplish stretch marks, especially in abdomen and thigh, and oligomenorrhea. And these happened 1 year before the presentation. And at that point of the time, the workup revealed a non-suppressed overnight dexamethasone cortisol with a value of 16.7 microgram per deciliter. And 11 p.m. salivary cortisol was 2.99 microgram per liter, which was more than 3 times the upper normal limit. And ACTH value was 120 picogram per ml, which was more than 20. So it suggests an ACTH dependent Cushing syndrome. And she underwent an MRI cella, which showed 7.78 centimeter hypoenhancing lesion in the left half of pituitary gland with displacement of infundibulous stalk to the right side. And at this point, patient did not undergo inferior petrosal venous sinus sampling or a CRS stimulation test or a high dose dexamethasone suppression test. And with this, the workup, patient underwent a first surgery in June 2019. Transnasal transsphenoidal excision of pituitary adenoma was done. We don't have an immediate post-op cortisol, but patient was given a steroid replacement for 1 month, and after 1 month, her cortisol AM was 13.4 microgram per deciliter, following which steroid replacement was discontinued. Importantly, histology revealed pituitary adenoma, which was immunostaining positive for ACTH with Ka67 index of 2%. And post-op MRI cella showed a residual lesion of 4 millimeter on the left side. So this was done 2 months after the surgery. Now, interestingly, she lost around 10 kgs after surgeries for next 4 to 6 months, and the menstrual cycle became more regular and stretch marks started to fade. And she also conceived with ovulation induction drugs and delivered in May 2021. And symptoms started again from early 2022, which include weight gain and oligomenorrhea. And she was again evaluated in September 2023. You can see the overnight dexamethasone cortisol was not suppressed. 11 p.m. cortisol, it was done, which was salivary cortisol, which was more than 4 times the upper normal limit. And ACTH was 82 picogram per ml, which suggestive of ACTH dependency. And high dose dexamethasone suppression test was done at this point, which showed more than 90% suppression, suggesting the ACTH dependency could be due to Cushing's disease. And she also underwent an MRI at this point, which revealed a lesion here on both sides of pituitary gland, which was 6.1 mm on the right half and 4.9 mm on the left half of the pituitary gland. An inferior petrosal sinus sampling or CRS stimulation test was not done. So with this, she underwent a second surgery in Jan 2024, and following which we have an immediate post-op cortisol, which was 15.9 microgram per deciliter, which showed the patient did not go into any form of remission. And histology revealed a pituitary adenoma of 3 mm in size with ACTH staining positive for ACTH, and Ka67 index was 2%. Clinically, here after the second surgery, there is no much improvement, and she was not given any medical options for hypercortisolemia. Now, she presented to us in Jan 2026 with all the typical features of Cushing's, which included weight gain, Cushingoid phases, supraclavicular fullness, and broad striae gain, oligomenorrhea, and hirsutism. And these are the biochemical workup which was done early this year in Jan 2026. You can see the ODS cortisol is not suppressed, and 11 p.m. cortisol, which was done twice, which was showing more than 4 times elevated, and 24-hour urinary cortisol was 352 microgram per 24 hours, which was more than 3.5 times of upper normal limit, and ACTH was done twice, which was 83 and 136, suggestive of ACTH dependency secondary to Cushing's disease. Now, do you think there is a need for IPSS at this point? I don't think no, because we have 2 histopathology evidence of pituitary adenoma with ACTH staining positive, which suggests the diagnosis of Cushing's disease as an etiology of Cushing syndrome. So these tests like high dose dexamethasone suppression test or a CRS stimulation test or IPSS are not needed, because these are tests which are done to differentiate between a Cushing's disease versus ectopic Cushing's. And this was an MRI which was done in February 2026, where you can see focal lesion on both half of the pituitary gland, and you can see the stalk which is in center. And these lesions, there are no supracellular extension of the lesion, And this is post-contrast images. You can see area of hypoenhancing nodules on either half of the pituitary gland with central stalk. And the lesion on the right side measured around 5 millimeter. On the left side, it measured around 4 millimeter. Now, let's just quickly review our journey of 7 years from 2019 till now, so that we just recollect all the things that we have said in the last few slides. So we have a 31-year-old female. In 2019, she had typical features of Cushing syndrome, diagnosed as ACTH-dependent Cushing syndrome, underwent first TNTS in 2019 with no documented biochemical remission, but she did have a transient clinical improvement and followed by successful pregnancy in 2021. Again, started to have the recurrence of symptoms from early 2022 with second TNTS, which was done in 2024. After the second surgery, she did not have any biochemical remission or any clinical remission, and she continued to have a residual lesion in the pituitary gland. And now we are in January 2026 with a persistent active disease with moderate hypercortisolism with a residual lesion in the pituitary. She has comorbidities include type 2 diabetes, which was fairly well controlled in her case with just 1 gram of metformin per day. She do have dyslipidemia and osteopenia. From the patient perspective, she is not mentally prepared for another surgery or intervention as of now, but she will consider later, maybe down the line 6 months to 1 year. But she does want some improvement in her symptoms of hypercortisolism immediately. Also, she wants to plan for pregnancy in the future, but it's not her immediate concern as of now. Now, can we have the poll question? So given her clinical scenario, what will you offer her now? Will you offer her a third TNTS as a definitive option, or a bilateral adenectomy, or will you offer her stereotactic radiosurgery, or you will offer her a long-term medical cortisol blockade, or a pituitary targeted medical therapy? Can we have the poll question now? I request all of you to answer this question. Remember, the purpose of the poll is not to test the knowledge, but rather to just explore how different clinicians prioritize each options over other in such a challenging scenario, right? So there could be even multiple ways of achieving cure in this case, may not be one correct way. Can we have the responses? Yes. Yes. So as I discussed, like you can see responses are dispersed among all the options with preference of bilateral adenectomy in 25%, which is interesting, and radiotherapy in 27%, and few people have opted for medical treatment. With very interesting thing is the third TNTS, only 5% of people have voted for. Okay. Now let's go into literature review. I would like to just focus on two key things. One, why did the surgery fail? This is one of the very important thing we have to answer in this case, because if in case we are planning for another surgery, if there is a factor that we can correct, so this could make a big change in the outcome of the surgery if you are planning. And second, what are the options now and how to select each options with respect to current scenario. Now, just let's review the treatment of Cushing's disease as an overview. You can see here, whenever we diagnose a patient with Cushing's disease, the first question to ask is transperineal surgery possible or not? If it is possible, then go for surgery. In the interim, if we feel the patient is having a moderate hypercortisolism, we can go for a pre-surgical medical treatment. If the surgery is not possible, maybe because of poor general condition, you can go for medical treatment. If the patient refuses for surgery, then you can go for radiotherapy, which along with bridging medical treatment till the effect of radiotherapy sets in. Sometimes if the hypercortisolism is very severe, life-threatening, you can even go for bilateral adenectomy as a treatment of choice in such scenarios. Now, once you do the surgery, what are the surgical outcomes that is possible? There are two surgical outcomes that can be possible after the initial surgery. One, if the surgery is failure, the patient can be labeled as a persistent disease, where the patient continue to have ongoing biochemical hypercortisolism with or without residual tumor. But if the surgery is successful, we can label the patient is having initial remission. Now, objectively to say the patient has gone into initial remission, we can use the first week post-operative cortisol of value of less than 2 microgram per deciliter. But some centers, they use little relaxed value of less than 5 also. If the patient has an initial remission, then we have to follow up the patient lifelong for recurrent disease. Now, a subset of patient may not undergo remission immediately, but they may undergo remission at the end of 3 months. This is called as delayed remission. It occurs because of delayed necrosis of the tumor tissue. So it's very important that before labeling the patient having persistent disease or a remission or has not gone into remission, we have to reevaluate at the 3 months value of cortisol and then take a decision so that you rule out delayed remission. Now, in our case, after first surgery, we don't have a proper documentation of biochemical remission, but there is a good evidence to suggest the patient had clinical improvement. So it could be a partial success. But after second surgery, we can label her as persistent disease. Now we'll go into the key factors that predicts the surgical outcome in patient with Cushing's disease who undergo surgery. Now first, let's see the factors related to tumor itself. Tumor size, right? If the patient is having microadenoma, then the chance of remission is almost 83%. If the patient is having macroadenoma, then the chance of remission is 68%. And second important factor is if the tumor is invasive into the nearby structures or the dura, then the chance of remission are very less, and the recurrence disease is also very less. I mean, it's very high. And if the preoperatively the tumor is not visible, if the surgeon is able to remove the tumor with capsule, then the chance of remission is 85%, but otherwise the chance of remission goes down to 60%. And if histologically, if you can identify the ACTR secreting adenoma, staining adenoma, then again the chance of remission improves. Some histological subtypes like Crook cell adenoma or a sparsely granulated adenoma can have increased recurrence rate because of their aggressive phenotype. And if the patient also has, if the tumor tissue on histology has positive for USP8 somatic mutation, again the chance of remissions is extremely high, but paradoxically these patients also have increased recurrences. And this subset of tumors, they overexpress SSTR5 so that the somatostatin analogs can be preferred in such cases. Now coming to the factors related to the surgery itself. Like surgeon's experience is one of the very key things that determines the outcome of such patients, because if the surgeon has an experience of more than 200 transperineal surgeries before the surgery, the chance of remissions are very good. And if it's endoscopic or microscopic way of doing surgery also can have impact on remission and recurrences. And center volume, especially the guidelines recommend the transperineal surgery for Cushing's disease should be done in a center where they at least operate more than 10 cases per year. And there should be a good institutional framework with a multidisciplinary approach to have good outcomes. And coming to the other factors, as we discussed in the previous slide, if the immediate post-op cortisol is less than 2, it says patient has gone into remission. And again, if the response to desmopressin in the early post-operative period to cortisol is less, it suggests the tumor has been removed completely, then the chance of remissions is high and the recurrence is low. And the duration of post-op adrenal insufficiency, especially like after surgery, if the patient goes into remission, if the patient requires a steroid, if the treatment of steroid is more than 1 year, then the chances of recurrence are very less. Sometimes we may misdiagnose an ectopic Cushing's as a Cushing's disease. So again, those patients also will have a persistent disease after surgery. Now coming to our case, patient had a microadenoma, tumor was visible in MRI, and surgery was failed twice. Like when I went back to the history, I felt the patient in both the scenarios of surgery was not operated in proper center, like it may not be the pituitary tumor center of excellence. So that could be the reason why the patient has not had a failed surgery in both instances. Now, if suppose the patient goes into remission, the recurrence rate is almost 5 to 35%, which is more for macroadenoma. And remember, most of such recurrences occurs after, like within 5 years of the initial treatment. Now, coming to the treatment options for recurrent or persistent Cushing's disease, to answer our second question, basically we have to address two important facets. One, we have to control hypercortisolism, and second, we have to control tumor growth. The options available are, we can go for transperineal surgery, which addresses both facets of the treatment principles. Second is pituitary radiotherapy. Again, it addresses both facets, but the control of hypercortisolism with pituitary radiotherapy may not be immediate. It may take some months to a year for the effect to set in. So it may require a bridging medical therapy. And third is medical management, again, which controls both. All the forms of medical management control the hypercortisolism, but the tumor growth control occurs only with the agents that act centrally like pestriotide and cabergoline. And bilateral adrenalectomy, it's a last option which definitely controls hypercortisolism, but its effect on tumor growth is like almost 30% after this procedure develop a Nelson syndrome, which is a very aggressive corticotroph adenoma, which requires multimodality of treatment to get remission in such cases. So this bilateral adrenalectomy should be kept as a last option. Sometimes we require a combination therapy to achieve optimal responses. Coming to repeat transsphenoidal surgery, so this could be preferred as an option when there is a tumor is very clearly visible in MRI, and mandatory IPSS is required if after the initial surgery we don't have a staining for ACTH secreting pituitary adenoma. If this is not there, then there is a need to go for IPSS before the subsequent surgery. And the remission rates after second surgery is around 58%, and this can increase to 75 to 80% in good centers. If the MRI is negative, and I don't think this could be a best option, until otherwise we have a very highly experienced surgeon who could do and remove the tumor with exploration. And remember one thing, because it's a second surgery, the complications are extremely high, and in terms of CSF leak and the chance of hypopituitarism are very high. So in our case, the patient also underwent second surgery. So that's the scenario here, which is also failed. But we still have an MRI showing a clear lesion. Now the question here to ask is, should we plan for a third TNTS or not? Now this should be weighed in the context of the risk that is involved in operating again in the pituitary fossa, along with what is the possibility that the patient after third surgery will go into remission. So with these two keeping in mind, things keeping in mind, then we can think of this option. The next option is pituitary radiotherapy. It is generally used for aggressive or invasive tumors with no clear target in MRI, or sometimes if the patient does not want surgery as a first option, then you can go for pituitary radiotherapy. It could be of two different types. It could be either conventional radiotherapy, otherwise called as fractionated radiotherapy, or a stereotactic radiosurgery. For doing a stereotactic radiosurgery, at least there should be a clearance of 3 to 5 mm of the tumor margin with that of the optic pathway, and almost 2/3 of patient after radiotherapy go into remission. And till the patient go into remission of hypercortisolism, there is a need to give some bridging medical therapy. It may last for months to years. And in terms of tumor control, 83 to 100% of patients with stereotactic radiosurgery will go into tumor growth control, and almost the number increases to 100% for conventional radiotherapy. Now, side effects include hypopituitarism, vision loss if the tumor is near the optic tract, and there is an increased incidence of cardiovascular events, cerebrovascular events, and also very small increase in risk of secondary malignancies. Now, coming back to our case, as 2 TNTS surgeries have failed, I think this we can consider as an option in our patient with a bridging medical therapy in comparison with another TNTS and the risk and complication associated with it. Now, in case if you are preferring this modality as a treatment in our case, as a definitive treatment in our case, then like we can go for stereotactic radiosurgery because we can have we does have a good clearance of tumor with the optic tract. Coming to the third option, that is bilateral adrenalectomy. So this is one of the very definitive option which almost offers 100% control of hypercortisolism. But it's not a first or second option. It's a last option that we should use in management of recurrent or persistent Cushing's disease. Sometimes we use this option earlier when the patient has a severe life-threatening hypercortisolism, but very rarely in some women who want to conceive immediately after the surgery, we can use this option, but this is not an option nowadays. The complication of this procedure is patient will require a lifelong replacement with glucocorticoids and mineralocorticoids, and 30% of patients after this procedure develop Nelson syndrome, which is a very aggressive form of corticotrophin adenoma. To prevent this, generally before adrenalectomy or just immediately after adrenalectomy, some people advise us to give radiotherapy so that it prevents Nelson syndrome. Now, in our case, should we consider this option? As I told, this procedure carries a lifelong risk of steroid replacement along with a risk of Nelson syndrome and aggressive adenoma. This should be kept as a last resort in our case. Now, coming to the medical management, we have drugs that acts at 3 different levels. One, drugs at the level of pituitary include pesidotride and cabergoline, and drugs that act the level of adrenal gland. Here it inhibits various enzymes of steroidogenesis pathway, which include ketoconazole, levoketoconazole, metriopone, mitotane, oscillostat, etomidate, and then we have mifepristone, which acts at the periphery level, at the level of cortisol receptors. So in our case, since the patient does not want an immediate intervention for 6 months to 1 year, but wanted to have a symptom relief, and she does have a moderate hypercortisolism, so there is a need that we have to select a medical therapy to control hypercortisolism as a bridge therapy till we have planned a definitive therapy for this patient. Now, coming to the agents, first agent we'll discuss is pesidotype. So it acts at the level of the pituitary gland. So it's a second generation somatostatin analog, which predominantly acts on receptor 5 along with 1, 2, and 3. And we'll consider this in case of milder hypercortisolism at baseline. So with this single agent itself, people will go into remission. And tumors on histopathology along with immunostaining positive for USP8 mutations. As I told, this set of patients, they express more of SSTR5, so they are more likely to respond to pesidotype, or it could be used as a part of combination therapy. Now, the formulation that is commonly used is a long-acting pesidotype in the dose of 10 to 30 milligram, which is administered monthly. And the UFC, that is urinary free cortisol normalization, occurs almost in 40% of cases, and tumor shrinkage occurs around 48% of cases. Now, coming to the adverse effects, this is very important because many of the patients with Cushing's disease also have a dysglycemia. You can see one of the important adverse effects is hyperglycemia or diabetes, which occurs in 72 to 82% to 85% of these cases. So we should be very careful in such patients. And cholelithiasis occurs in 20 to 30% of cases. And the other effects include GI side effects, QT prolongation, and transient liver enzyme elevation. Clinically, to consider, we should do a baseline assessment of the glycemia and also liver function and ECG before considering this treatment. If there is failure to control the urinary free cortisol in the first few months of therapy, then it's not a very good prognostic factor of continuing the drug. So we can take a decision at the point of 2 to 3 months of initiation. The next drug is cabergoline. It binds to D2 receptor because almost 30 to 80% of patients with ACTH secreting adenoma, they express D2 receptor. And the dose range from 0.5 milligram to 7 milligram per week, given in 2 to 3 doses, which is substantially more than that we use for usual prolactinoma. And the normalization of urinary free cortisol occurs in 25 to 40% of cases. Here, very important point to notice like almost 20 to 40% of the patient who initially have a normalization of the urinary free cortisol, even with continuing therapy, their urinary free cortisol starts to increase. So this is called as treatment escape, and this is described with various agents that they use to treat for hypercortisolism. And long-term remission rates are 20 to 23%. And we have to monitor for side effects, very importantly for impulse control disorders, and 2D echo for valvular fibrosis if the dosage increases more than 2 milligram per week. We will consider this agent in very mild hypercortisolism, and again we have some good data on pregnancy, and most of the time it is not used as a monotherapy, but rather with the other agents like steroidogenesis inhibitor as a part of combination therapy. Now let's go into the steroidogenesis inhibitors. The first that we are going to see is ketoconazole and levoketoconazole. Here, ketoconazole is a mixture that contains both the levo and dextro enantiomer of ketoconazole, whereas levoketoconazole contains only the levo enantiomers. So it acts on various enzymes. So it inhibits the side chain cleavage and 17 alpha hydroxylase, 11 beta hydroxylase, aldosterone synthase. So it inhibits steroidogenesis pathway at multiple levels. Now, this slide gives a comparison between ketoconazole and levoketoconazole. I'm not going through entire slide, but let me just highlight the difference here. The dosage is almost similar in both the drugs. In terms of efficacy, if you see, the levoketoconazole performs better. Like in ketoconazole, you see 50 to 60% of patient has a normalization of urinary free cortisol as opposed to 81% with levoketoconazole. So it's more effective in controlling of the urinary free cortisol. And common adverse effects are similar, but the major safety concern with respect to hepatotoxicity, the reported effects are much lesser when comparing to ketoconazole. Now the next agent is metriapone. So metriapone acts predominantly at the level of 11-beta hydroxylase and aldosterone synthase. The next three agents that we're going to see, they act at the level of 11-beta hydroxylase. Now, one thing which is very specific about metriapone is that it has a very rapid onset of action, and so this can be an agent which can be preferred when you want to control the hypercortisolism rapidly. And again, we have a good data for metriapone in pregnancy, and the normalization of urinary free cortisol occurs almost in 43 to 76% of patients, and with the treatment escape of 18% of patients. So this also you should keep in mind. And the next drug is osilodrostat. It is the mechanism of action is similar to that of the metriapone. It inhibits predominantly the 11-beta hydroxylase with effect on aldosterone synthase, but at higher dosage, it also has some effect on 21-alpha hydroxylase and 11-alpha hydroxylase. But the predominant effect is on 11-beta hydroxylase. Now, just similar to metriapone, again, it has a very rapid onset of action, and most importantly, the urinary free cortisol normalization occurs within 5 weeks. And the dosage starts from 2 milligram to a maximum of 60 to 80 milligram per day. As per the link 3 and 4 phase 3 trials, the urinary free cortisol normalization occurs almost in 75 to 86% of patients. So this is one of the most effective medical treatment that we now have for treating the hypercortisolism. And importantly, the pituitary tumor enlargement occurs in 33 to 40% of cases. The next agent is etomidate, which predominantly acts similar to the previous two drugs at the 11-beta hydroxylase and aldosterone synthase, with some effect on 17-alpha hydroxylase. As we know, this is an anesthetic agent, so this is used only in severe life-threatening cases in ICU setting as an IV infusion. And here the cortisol normalization with respect to titration occurs as early as 12 hours to 24 hours and has an 100% efficacy. And the side effects include sedation, respiratory depression, myoclonus, and cardiac arrhythmia. And because this etomidate has a vehicle which contains propylene glycol, so we have to monitor the toxicity related to this propylene glycol also, which include lactic acidosis and renal tubular injury. The next agent is mitotane. So mitotane inhibits multiple enzymes, including side chain cleavage, 11-beta hydroxylase, aldosterone synthase, 21-alpha hydroxylase, 3-beta hydroxysteroid dehydrogenase, also 17-alpha hydroxylase. So it inhibits a variety of enzymes. So we can call it as a pan-enzyme inhibitor. Along with, it is also adrenolytic. It causes damage to mitochondria and endoplasmic reticulum. So it causes death of adrenal cortical cells. Now, it's predominantly used in adrenal cortical carcinoma, but very rarely in Cushing's disease, we can use when very refractory and recurrent cases, when all the other agents that we listed before failed. So this should be kept as a last option for Cushing's disease. Coming to the last agent, mifepristone. So this agent acts at the level of periphery, at the level of cortisol receptor, where the cortisol goes and binds to the glucocorticoid receptors in the cytoplasm. So it's FDA approved for treatment of hyperglycemia and endogenous Cushing's syndrome. Because it acts at the level of cortisol receptor, you can expect a reflex increase in ACTH and cortisol levels, and there is also an increased risk of tumor progression. And for monitoring, this agent, it's monitored only based on the clinical endpoint rather than biochemical features. And coming to the selection of medical therapy in Cushing's disease, this is an important slide. So this slide says how we have to select the agent for, especially the medical agent for Cushing's disease. The first and foremost important is disease severity. If the disease is very severe, if you want to control the hypercortisolism fast, I think the best agents will be osilodrostat and metriapone. If the disease is very severe and life-threatening, then you can go for etomidate. But otherwise, for mild to moderate cases, we can start with monotherapy of the medication that we mentioned before at a lower dose and titrate. And second important factor is tumor characteristics. Especially if you have a large residual tumor, better you start with a drug that acts centrally. Maybe this drug should be a part of the combination therapy also. So which include pestriotide and cabergoline for tumor shrinkage. And if the tumor expresses USP8 mutation, again we have to prefer pestriotide because of increased SSTR5 expression in such tumors. And patient-related factors, in female patient, we can use ketoconazole because it also decreases androgen. And male patient, better to avoid because the ketoconazole causes gynecomastia. And in pregnancy, we have some data regarding cabergoline and metriopon, but not for other drugs. And definitely mifepristone and mitoten should be avoided because it is teratogenic. With respect to comorbidities, if the patient has diabetes and hyperglycemia, definitely we have to avoid pestriotide because it can worsen underlying glycemic status. And mifepristone is an agent that is preferred if the patient has diabetes along with multiple failed surgeries. And if the patient has liver disease, try to avoid ketoconazole and pestriotide. And if there is a pre-existing psychiatric illness, we have to avoid cabergoline because it can exacerbate a bipolar or impulse control disorders. In terms of titration, if the patient has a moderate disease, then we can start a drug with a lower dose and up titrate till you control the hypercortisolism and avoiding adrenal insufficiency. But if the patient has a very severe disease to start with, then you can use something called as block and replace strategy, where you start simultaneously the drug at a reasonable good dose so that you want to control hypercortisolism immediately, along with a fixed dose of glucocorticoid so that the patient may not land up in adrenal insufficiency. So this is especially very useful in cases where a severe hypercortisolism is there and you want to control the level of hypercortisol rapidly. And combination therapy always comes in hand because when you combine two drugs, we can use the two drugs at the lower doses so that the side effect profile can be minimal and the patient better tolerates the drug. Also, we can club an agent which acts at the periphery along with the central so that you get a good synergetic effect. And in terms of monitoring while on Cushing's disease, the most important parameter that we have to monitor is urinary free cortisol, which is mentioned in most of the studies. So this will be used as a parameter to determine the drug titration, and at least 2 to 3 samples should be used, values should be used before adjusting the dose. And late night salivary cortisol to test for circadian rhythm. So this we can use once the urinary free cortisol is normalized. So what data says is if the urinary free cortisol is normalized, if the late night salivary cortisol also normalized, then such patients, they have a better CV and metabolic outcome. And third parameter is morning serum cortisol. So this can be used to detect whether the patient is having a correct level of treatment or if there is a risk of adrenal insufficiency or not. If the morning AM cortisol, like with medical therapy, is less than 5 microgram per deciliter, then it says patient is having an impending adrenal insufficiency. Optimally, you can have a cortisol level of 8 to 10 as a target range for titration of the medical therapy. And assay consideration, this is one of the very important point to note on drugs that predominantly act on long beta hydroxylase like metriopon and osilodrostat, because the conventional immunoassays, they may have a cross-reactivity of 11-deoxycortisol, which is much higher in people being treated with metriopon and osilodrostat. So that when you measure cortisol in such patient, the level of cortisol may not be accurate. So this cortisol that you measure could be overestimated because of excess level of 11-deoxycortisol, which interferes with the cortisol assay. So the best way to measure is either tandem mass spectrometry is the best way in such cases, or an assay that measures cortisol with least interference with 11-deoxycortisol. And any agent that we use periphery may be the adrenal steroidogenesis inhibitor or the mifepristone, which acts at the receptor level. It's imperative that we should monitor the cellular tumor for growth, and we do MRI every 6 to 12 months, and thereafter, as per the clinical suggestion, to see if there is any increase in tumor size. And the last is mifepristone is a drug with this exception, as I told, because it acts at the level of the glucocorticoid receptor. We don't have any parameter to monitor in this case objectively. So whatever the dosage titration occurs with respect to the clinical parameters. And importantly, if the patient on mifepristone develops adrenal insufficiency, again, we don't have any biochemical parameter to substantiate it. So best way will be to treat the patient clinically, even for suspected adrenal insufficiency. Now, in our case, after all this review, with respect to many other factors, we started the patient on osilodrostat and she responded very well. Currently, she is on 5 milligram daily with very significant clinical improvement, and her urinary free cortisol has decreased to 110 microgram per day. Remember, it started with 350 microgram before we started the drug. Clinically, she responded very well to this drug. Now, the questions to the professor is, given a clinical scenario of 2 failed TNTS and MRI showing a residual lesion, what will be the treatment of choice in our case? Do you recommend a third TNTS or any other modality like radiotherapy? And since 2 surgeries have failed, will you consider radiotherapy along with the bridging medical therapy as I told before? And is there any role of bilateral adrenalectomy in this case? So, and then if the patient wants to plan for pregnancy in 6 months, we'll have a treatment change. So with this, I conclude my talk and give the over to the session to the Professor Melmet for his valuable suggestions. Thank you.
Can you hear me now?
Yes, Prof, we can
Yes,
hear
Professor. Yes, Prof.
Can you hear me?
Yes, Professor Melmet. Yes.
Thank you. Okay, so that was a terrific talk, and it was a very, very complicated patient, and you did a beautiful literature review and a beautiful assessment. There's not much for me to add. So I thought what I would do is I would give you a brief suggestion based upon some background literature and some background opinion about this patient. First of all, she's clearly got a persistent Cushing's disease, and you've made the diagnosis of ACTH-dependent Cushing disease. You've had multiple evaluations, and now you're asking me a very appropriate question as to what is going to be the next step. So Cushing's disease is, as represented by this patient, is a very severe condition. For the young people in the audience, I always like looking back at history, and the lyre sign, there's the Greek lyre, and there's the classic lyre sign on the left, is classical for the striae of Cushing's, and the presence of a small microadenoma is a classical dyad, so you have peripheral effects of hypercortisolism and evidence for the production of ACTH by an adrenal adenoma. And you are absolutely correct, and no need for you to perform an IPSS because you had the pathology slides to show you that this was indeed a ACTH secreting adenoma. So the big question which you're facing in your patient, and which we all face in these patients, and it's not a simple answer. How do we as endocrinologists impede the excess production of ACTH? And you gave us a beautiful overview of the approaches that we could use today. And because there are so many approaches, and because there are so many drugs available, and because there are so many opportunities for different management scenarios, that tells us that there's no good answer. So whatever we're going to suggest is not going to be an optimal answer for our patients, and we have to work with the information that we have, the evidence that we have, to try and offer our patients an approach to treatment. So One of the questions which you very appropriately raised and you reviewed nicely is surgery. Should this patient have third surgery? Well, what are the determinants of surgical outcome? And you reviewed some of them, but let's put them all into a perspective. In the experience of the literature, the most significant determinant of surgical outcome is not the skill of the surgeon, because they're all skilled. Our surgical colleagues are all skilled, but the experience of the surgeon with pituitary resections. And there are several studies now showing that the surgeon who performs more surgeries focused on the pituitary gland, who has 2 or 3 surgeries undertaken every week, is going to experience better outcomes than the surgeon who only operates once a month or once in 2 or 3 months. I can tell you in the USA, the surgical experience is not optimal for pituitary surgery because the majority of pituitary surgeries in the USA take place in centers who see less than 10 patients a year requiring pituitary surgery. And so therefore, when we see the literature and we compare the literature results to the results we see with our patients, remember we're comparing the literature as written by very experienced neurosurgeons who are operating on many patients with Cushing's disease or acromegaly or non-functioning adenomas. I don't know what the experience of your neurosurgeon is. I would imagine that your neurosurgeon is a very skilled surgeon, but I don't know what the volumes are. But that is a significant determinant of outcome. So the number of prior surgeries is statistically validated now in at least 3 studies showing that the higher the number, the better the chance of a surgical remission. Clearly, adenoma size and invasiveness is important, and the more invasive the adenoma is, the less opportunity for a good surgical total excision. I was surprised that your patient's Ki-67 with recurrence is only 2% or less, and that is a surprise, and one would have expected a recurrent adenoma with what you've described to have a higher Ki-67. And then, of course, the patient status for their clinical and biochemical phenotype, the level of hypercortisolemia, the level of all the systemic side effects which you reviewed so nicely of Cushing's, of hypercortisolemia. All these phenotypes are going to have adverse impacts on surgical outcome. But most importantly for us as endocrinologists, the opportunity for a biopsy material obtained by surgery will in fact guide medical subsequent treatment. For example, as you mentioned correctly, by measuring a somatostatin receptor 5 or looking at USP8 mutations will in fact give us some hint to guiding medical treatment. These are still early days. We don't yet have rigorous prospective trials telling us that the presence of SST5 or USP8 mutation in the adenoma will give us a specific outcome target achievement. And those trials hopefully will come to fruition over the next few years. And also, most of our pathologists in clinical practice don't routinely measure SST5 expression or certainly not a USP8 mutation. So these are very early days, and if you are in the situation where you really want to know this, you have to speak to your pathologist before the surgery to make sure that they're geared up to be able to analyze SST5 and USP8. So let me just give you one example which just came out a few months ago. This is an example of a multi-center trial looking at USP8 mutations in these adenomas and seeing if it does in fact impact surgical outcome by measuring time to recurrence after the first surgery over a matter of 120 months. This is a long study, and obviously it was retrospective because it was so long. But if you look at the USP8 mutation carriers in the red, compare their time to recurrence after first surgery to those patients with microadenomas in the pale blue as compared to the patients with macroadenomas in the dark blue, you can see that there does appear to be a shift of outcome, more adverse outcome with the mutation moving towards macroadenomas from microadenomas. Whether or not this is going to hold up, we don't yet know. This is one of the first trials. You also mentioned that there's some data in the literature of the opposite, that a USP8 variant may in fact predict a better outcome. So we don't yet know, but we're now in the exciting phase of perhaps offering our patients a window opportunity to be able to understand how the molecular analysis which our pathology college performed for us may in fact give us some opportunity to look at USP8 outcomes. So what do we do for your patient? Do we offer your patient any of these on the left, pituitary directed, peripheral receptor directed, adrenal directed, or a cellular directed medical approach? And you reviewed these quite beautifully, so I'm not going to go into any detail. Clearly, any of these will require very, very concerted effort on your part, because all of these drugs have side effects. Their efficacy is, as you correctly pointed out, is very broad, and it is very difficult to really focus on a specific one, especially in a patient like yours who has undergone failed surgery. So I clearly believe that from my perspective, what I would do with a patient that you're presenting today is I would offer this patient radiotherapy. I would offer them radiotherapy with one of the adrenal-directed drugs that listed over here on the left, and I would probably start with levoketoconazole or osilotrostat and use these to inhibit adrenal production of cortisol while the effects of radiotherapy are taking place. Targeted radiotherapy will require sometimes years to be maximally effective, so your patient will need coverage. And I would choose adrenal-directed targeting coverage for your patients after they have received their radiotherapy. I would not favor bilateral adrenalectomy because although it is very effective, clearly you remove the adrenal glands, you remove all the possibility of excess cortisol production, so it is very efficacious. You get immediate hypercortisolism control, up to 90% or more efficacy. However, the side effects are that you're going to cause permanent hyperadrenalism, as you pointed out, and these patients require lifelong glucocorticoid and melanocorticoid replacement and the development of Nelson syndrome, as you correctly pointed out. So in my mind, the value judgment for bilateral adrenalectomy is not worth the benefit because of these side effects. And Nelson syndrome is extremely difficult to treat. And here's an example of a young patient with Cushing's disease. And you can see over here that after adrenalectomy, she actually develops hyperpigmentation, which you would expect because you're now releasing the pituitary gland from feedback inhibition by the adrenal steroids if you've removed the adrenal gland. So she's developing hyperpigmentation, classic feature of Nelson syndrome. But most importantly, even as she gets darker and darker, her pituitary mass grows very aggressively, and even lifting the optic chiasm in this patient and actually invading the laterally east and west into brain tissue. And so Nelson syndrome is an extremely difficult condition to treat and eventually will require radiotherapy possibly as well. So you may as well start with radiotherapy first. And that is why my personal bias, reading the literature, understanding what you correctly reviewed for us with your risks and benefit, I don't believe that these risks are worth exposing your patient to bilateral adrenalectomy. I would certainly prefer, especially in a young patient, your patient started out her disease, she was only 31 years old, I would not favor bilateral adrenalectomy. So if you look at the overall panorama that we're facing as endocrinologists, and your case is a beautiful demonstration of this, of the fact that the reality of treating Cushing's disease still today is quite challenging. And I look forward to hearing Dr. Tabarin's view of things, because he is an expert in the disorder. But achieving remission in patients with very resistant Cushing's is very challenging. As your patient underwent first surgery after very good diagnosis and pre-surgical workup, you did an excellent job. You underwent first surgery, then the adenoma recurs, you underwent second surgery, and now there is recurrence again. My suggestion at this point would be radiation, and after radiation, the patient may still recur or may still have persistent disease, and this patient will enter what we call a chronic disease window, which may last for many years. And at every step of the way, we have the tools now, we have the medical therapeutic approaches, all the ones we outlined on that figure of the targeting of the pituitary, the periphery, the receptor, the intracellular. We have those targeted therapies, and we can start pushing these therapies into the patient to try and slow down this chronic disease progression of, again, remember my first slide, trying to block ACTH hypersecretion. And so I think you've done this very effectively. It's a challenging patient, and my suggestion would be that you send her for a very targeted radiation. The residual mass appears to be quite far away from the optic chiasm, and so the danger of visual impairment is not absent, but it's certainly much lower, and therefore I think that she would in fact benefit in the long term from radiation, as long as you cover her medically in the meantime with one of those targeted therapies that you reviewed so beautifully. So I'm going to stop there and take the opportunity for questions. Thank you.
Thank you so much, Professor Melmet, for your commentary and kind guidance. I think for the sake of time, we will keep the Q&A at the very end of the session. And today I have a very, nice opportunity that we have two eminent professors in their respective field. And let me introduce for the symposium by Recordati Rare Disease and our eminent speaker, Professor Antoine Tabarin, whose name is doesn't need any introduction, but still I have to tell that he's a professor of endocrinology at the University of Bordeaux and head of endocrinology at CHU Bordeaux, France, International Authority in Cushing's syndromes, adrenal tumors, and pituitary disorder. He has co-authored major international guidelines, including Endocrine Society in 2015 and Pituitary Society of 2021 for Cushing syndrome and disease, respectively. He's a renowned clinician scientist with extensive contribution to clinical research in adrenal and metabolic endocrinology. Today, Professor Antoine will talk about the role of pasireotide in the treatment of acromegaly. And please, Professor, can you please share your screen and start your presentation? Thank you so much.
Okay, thank you. So I thank the organizer Enrico Dati for allowing me to present this talk. Do you see my screen?
Yeah, we can hear you well and can see your screen.
Okay, thank you. So here's my disclosure. Well, Professor Melmet already mentioned a number of things, so I will go very briefly just to remind you that pasireotide, as opposed to first-generation somatostatin analogs, targets is a PAM receptor agonist, SSTR receptor agonist, and targets also some receptors that are not targeted by octreotide, like SSTR5. So there has been a huge number of studies, development studies, performed initially by Novartis and also Recordati. I will just mention the results of some of these studies. Just to mention also that I know that the pasireotide LAR is now approved in your countries with a similar indication to those in Europe. So acknowledging that it's indicated in the treatment of adult patients in whom surgery is not option or has not been curative and who are inadequately controlled by another stomatostatin analog. So it may be considered as a second or third line treatment. So among the study performed by the industry, I think that the Paola one is one of the most important because it was performed in patients that were not controlled by a maximum dosage of first generation agonists for several months. And these patients were either continued as a control group with their initial first generation agonist treatment or switched to pasireotide LAR 40 milligram or 60 milligram every month. And one of the primary endpoint was the control of the disease with the biochemical criteria that were active at this time. And as you can see, we will focus mainly on the middle of this slide on IGF-1 normalization. IGF-1 was not normalized in patients maintained on their first generation agonist analog. So this is expected since they were resistant. And in this very specific population, you can see that a quarter of patients treated with pasireotide were able to normalize IGF-1. So this is one study, a small study initiated by our group as soon as the drug was available in our country. And this small study, but I want to mention it, it concerned 15 patients that were all operated first and then treated by combined treatment of somatostatin analog first generation and maximum dosage plus pegvisomant. So these were patients that were resistant to first generation somatostatin analog and needed an association with pegvisomant. And these patients were systematically switched to pasireotide. You have here on the graph, on the left side, their initial IGF-1. You can see that some were controlled while some were uncontrolled. And then you have the evolution following pasireotide introduction as a switch for approximately 2 years. The dashed line are patients in whom the drug was discontinued in most patients because of intolerance. But you can see that in the majority of these cases, we were able to control with only pasireotide. We were able to control 8 of these 15 patients. And in terms of glucose tolerance, I will come back on this. You can see here that it was acceptable with, at the end, a median HbA1c of 6.1, and only 2 of these 8 patients required initial oral anti-diabetic treatment. So in our hands, on this very first study, you can see that half of patients resistant and necessitating surgery plus somatostatin analog plus pegvisomant could be controlled with only pasireotide. One interesting thing with the use of pasireotide, and I come back here to the Paola study, is that after 3 months at week 12, you already know if your patient will be sensitive or not to the drug. So if you are following a trial and error approach, so introducing the drug and looking at its effect, you know that if IGF-1 and GH has not decreased after 3 months, your drug will probably not be effective in the future, and you can think about another therapeutic option. Another point is, the anti-tumoral effect that is well known with somatostatin analog. And again, back in the Paola study, you can see that patients that were switched to pasireotide were able to have a decrease, a significant decrease, more than 25% of the volume compared to patients maintained on somatostatin analog. Indeed, 11 to 19% of patients had a decrease in their complementary decrease in their tumor volume. There was an extension phase in this study, meaning that the patients that were treated by first generation analogs were switched to pasireotide, and patients treated to pasireotide 40 milligram were switched to 60 milligram. So what we can see is that after 1 year, you can see that 27 additional percent of patient versus only 5.3% of patients treated with octreotide achieve normalization of IGF-1. And on the long-term outcomes of this extension phase, you can see that 37% of these patients that were switched to pasireotide experienced at it as one time stringent criteria of control, meaning normal IGF-1 plus GH below 1 microgram per liter. So indeed, it really shows that there is an additional impact of the drug in terms of biochemical control of the disease. And in this meta-analysis of the literature conducted in the real world outside the studies performed by the industry in patients that are resistant to first generation somatostatin analog, you can see that approximately 60% of patients achieve IGF-1 control during pasireotide treatment. So Professor Melman also mentioned the multidimensional care of the disease actually. And if we look at the symptoms following the extension phase, you have here in blue the patient who experience an improvement in their classical symptom of activity of the disease. And you can see that a significant number of patients, more than, let's say, roughly 1/3 of patients are really improved. And of course, this improvement in symptoms also results in an improvement in quality of life. I want to specifically mention the headache issue, since this drug really seems to perform far better than first generation agonists in terms of relief of headaches. So about the anti-tumoral activity, it's interesting to see this data coming from the Netherlands. It's an extension of previously published studies in which patients were treated by a combination of pegvisomant and pasireotide. And what you can see here is that the tumor volume across time, and you can see in the patient a progressive decrease of volume of the adenoma with time. And in this study, you can see here that the volume really dramatically decreased with time. And you have what our colleague have described, these cystic changes within the adenoma, meaning in T2 MRI, the apparition of very blank-like liquid zones within the adenoma. And interestingly, in this study of 44 patients, the author mentioned that 12 patients experience a reduction during the chronic treatment of their medical acromegaly treatment without the need of surgery or radiotherapy due to the decrease in IGF-1. So there have been a lot of studies to try to do what is called the personalized medicine and try to select which patients are the good candidate for pasireotide versus third generation agonist. And these are summarized here. A number of parameters may not be available in your center, like appreciating as the AP expression or the E-cadherin expression, or maybe you do not routinely perform SSTR2 immunostaining in your operated patient. And of course, if patient have not been operated, then you can't have this data. But there is a quite simple probabilistic tool that you all have that can in some way predict the performance of pasireotide. It's looking at the signal in T2 MRI, so that you can compare the intensity of the tumor, adenoma, versus gray matter. And if you have darker, and you can do it by eyeball analysis, you can have a darker area in your adenoma. It's an intermediate marker of the granulation, it's a densely granulated pattern. And the densely granulated pattern is also correlated to SST2 expression. So these patients are more prone to respond to first generation somatostatin analog, while those with this aspect, so similar or increased intensity compared to the gray matter, it's an intermediate marker of sparsely granulated, which is more frequently associated to response to pasireotide. This is shown here. You have here, you can see here that considering a 50% reduction in IGF-1, you can see that patients that are hypointense, there is only 10% who are not responsive, while to first generation agonists, lanreotide and lanreotide, and you can see that a majority is responding when it's hypointense. And we have exactly the same, as I mentioned previously, about the densely related and sparsely related for pasireotide. So talking now, we have talked about the efficiency in terms of biochemical control, about tumor shrinkage, but there is also the issue of tolerance. So the side effects of second generation are almost similar to that of third generation, with the exception of glucose tolerance. As you know that insulin and incretin receptor are expressed in the gut, and SSTR5 receptor are expressed in the gut and in the pancreas. And since the drug pasireotide targets very actively the SSTR5 receptor, there is a decreased secretion in incretins and in insulin. So when we look at the Paola study, and this has been confirmed by many studies, you can see that the patients that are more prone to develop diabetes during pasireotide treatment are patients that are already diabetic or pre-diabetic at time. It's also true for obese patients and older patients. But as you can see here in the Paola study, the increase in glucose level were quite a rare cause of discontinuation of the drug. Nevertheless, this is an important parameter you have to take into consideration. First, to choose a drug, and also to monitor and to actively prevent or treat these side effects. And these are recommendations that have been written by some colleagues, is that about follow-up, that in patients that are low risk, since they are young, not obese, and do not have pre-diabetes at start, you can perform self-monitoring blood glucose every 2 weeks, and also fasting and postprandial glucose levels. In patients that are high risk, you will increase the frequency once weekly. And of course, if you are pre-diabetic or diabetic patient, to do it daily. This is true for the first 3 months, but one interesting thing is that this hyperglycemic side effect occurs very rapidly. It occurs usually within 2 weeks or 3 weeks. So you will know very rapidly, very soon after introducing the drug, if there is an issue about glycemic tolerance and side effects. And in terms of treatment, I think it's already important to prepare your patient. And I think there are large indication of metformin in predisposed patient. Or you can also use, since I have mentioned the role of pasireotide on incretin secretion and insulin secretion, use a GLP receptor agonist or DPPI inhibitors as a first line treatment. And of course, if this line do not work, you can add the missing drug. There are some speculation about the use of a SGLT2 inhibitor, more specifically in patients with a cardiovascular or renal risk. And finally, if metformin, GLP-1 agonist or DPPI doesn't work, you can consider adding a third anti-diabetic agent or insulin. And of course, if your patients are already insulin treated at start, it's not an issue. You just continue insulin, and you may have to increase maybe the dosage. So I will end with just a brief case from our series.
I think Professor Antoine may have experienced some internet disconnection. So till he take over or get control of his internet, let me ask the 2 questions which are posted by the attendees, that if Dr. Melmet can kindly address them. That if a patient who has Cushing disease and is getting treatment by TSS and in remission, how to follow the case if salivary cortisol is not available in their home country? So what would be your advice, Professor Malmet, in these kind of cases?
Well, it's a very difficult and challenging question because even salivary cortisol has very wide variations. So I'd say in that circumstance, I would follow the urinary free cortisol collections. Just make sure that you're happy with your lab's consistency for urinary free cortisol measurements because sometimes they're also all over the place, and you've got to make sure your collection is accurate. And most patients don't understand collection instructions. And it's very important that sometimes even perhaps it's worth sending a nurse to the home to make sure that they're following the collection instructions. So I would do urinary free cortisol. And if you can't do that, then I would resort to an 8 a.m. morning cortisol blood level. But I think that salivary cortisols you can actually get by mail sometimes. So it may be an opportunity for you to try. I don't know what city you're in or what's your nearest big city, but sometimes it's available by mail.
Yeah, perfect. So another question is, I think Dr. Antoine joined us.
Yeah.
Okay, let's resume with your talk, Dr. Antoine, then we will resume our Q&A sessions. Probably he's still facing technical glitches. So, Dr. Malmer, there is another question that if there is acromegaly in the background of cystic pituitary adenoma, which best line of therapy for those cases?
Well, I think that even for a cystic adenoma, I would certainly look at the first opportunity for surgery if the patient is agreeable and if they are otherwise sufficiently healthy and their metabolic situation is sufficiently stable for an anesthetic risk, I would recommend surgery for those patients.
Thank you so much. This is exactly the first line of treatment in these cases. And another attendee is asking regarding the case presented by Dr. Murugan. He wants some clarification that if the patient is planning to get pregnant, still you are considering the option of radiotherapy and osteodorstate, or should it be a bilateral adrenalectomy? I think it has been answered very clearly by you as well as the speaker. But if you want to comment on further.
I think that first of all, the patient can always freeze their eggs, and that we would recommend that. And then at the end of the day, it's a value judgment of the requirements and the need and the wish of a woman to be pregnant versus her own health. And it's a value judgment, and only the patient can decide that, not the doctor. So in a dialogue with the patient, I always have the conversation at the end of the day is, what does the patient want? Is their own health and long-term morbidity more important to them than becoming pregnant? And sometimes it's a very difficult decision, and at the end of the day, it's individualized, so there's no uniform answer. But today with the opportunity to freeze over, it's a big help for us and for our patients.
True. Another attendee is asking for the case similar to the one presented, but they're addressing that the case was without having a histopathology report, and the lesion was 7 mm with 2 failed surgeries. They don't have access to the final histopathology report, KI index, and acetated staining. So in that case, what would you advise? It should be done prior an IPSS before proceeding further or taking the decision about the third surgery?
I think you can always mail the slides for immunochemistry. So today there should be no problem with anybody anywhere in the world. Once they have the slides, that they've had surgery and the pathologist has prepared the slides, even if they don't have opportunity for immunostaining, they can mail the slides to any big center, and you can have immunochemistry performed. Again, I don't know what city this is and what country it's coming from, the question, but I would imagine that most countries have that opportunity. If that is not possible, then you can ask your pathologist without immunostaining to just tell you, is there or isn't there an adenoma? And that may be helpful and reassuring to the physician that they're on the right track. If they, even on the simple H&E staining, that they see evidence for an adenoma. It's important in that circumstance to ask the pathologist to look at the reticulin, because disturbed reticulin is pathognomonic of adenoma, and if the reticulin is destroyed in the image, that is almost, not 100%, but almost a definitive sign of adenoma. So there are some of these opportunities not necessarily focused on the unavailability of immunochemistry.
Okay, perfect. So I think it's still, we could not get Dr. Antoine here, and I think we don't have any further question here. I would really like to thank you, Professor Malmet. It was really very enriched experience having a dialogue with you and having shared our experience and difficult cases. And it was such a pleasure to have you here. Thank you so much.
Thank you. And the cases were beautifully presented. They really were excellent presentations. Congratulations to the presenters.
Thank you so much.
Thank you, Professor.
Thank you, Doctor. Thank you, Professor.
So I would like to thank you, all the delegates and the speakers and Professor Malmet and all the attendees to stay. We little exceeded the time, but I think it's worth this because the cases as well as the discussion was really interesting. So we, as you know, this initiative of EDES Exchange, Meet the Professor by Endocrine Diabetic Society of the UAE under the privilege of MCI, we are having an open invitation that if you're having a challenging case from your practice, which you don't find answer within your institute or the existing guidelines, so please be our next speaker, share your insight. Please scan this QR code, submit your case, and if after the filtration it's fit into any of the upcoming episode, we will invite you and you can have a presentation with us, with all the eminent speakers across the globe. So this initiative is really going to help all the practicing physicians and endocrinologists to share their experience and the challenges. And we would be glad to spread the word across all the societies and the endocrinologists. So please go ahead and share it. Another reminder about the upcoming Young Leader Forum from the same platform of Emirates Diabetic Endocrine Society for Precision Endocrinology. This is going to take place on Wednesday, 24th June. And it's going to be a very interesting seminar. Please do attend this, followed by another learning initiative in combination with the EDES and Sharjah University. This is a research ethics in DHA. Speaker will be Ms. Medha Kulkarni. It's on 25th June, Thursday. And another reminder, the CME certificate will be available after 4 weeks of the webinar, and you will receive an evaluation. Please send your suggestion and in the evaluation form and the registered email ID, you will be able to get the CME certificates. Those who have missed part of today's webinar, they can still go ahead and get the remaining talk on the EDES Institute. Thank you and have a lovely day and lovely night, all of you.